Thank you, Chirag. Good evening, everyone. Thank you, Chirag, for the kind invitation. Can you see my screen?
Yeah.
Yeah. And thank you, Bangalore Orthopaedic Society and Bangalore Arthroscopic Club. Good evening to everyone. It's nice to be here virtually at the Bangalore Society. My topic is on decision making in soft tissue Bankart, and especially approach to first-time dislocators. So what do you recommend here? Yes, the knee chapter has been completed as per the Bangalore Orthoscopy Society, but this is the shoulder meeting. But I'm just putting this one, patient with the ACL tear. What do you recommend? You quickly make a decision. The patient needs ACL reconstruction. Why? Because you are concerned about the risk of re-injury to the knee, a joint damage, and functional loss. My question is, why not respect the shoulder? If you look at it, that's the IGHL with the anterior band and the axillary band, which is connected to the antero-inferior labrum. The classical dislocation of shoulder is not anterior, the common is antero-inferior. So what we are talking about is the antero-inferior labral tear from 2 to 7 o'clock, if you look at the clockwise, and that is the attachment, the hammock, the support provided by the inferior glenohumeral ligament. So this together, the inferior hammock with its attachment to the labrum and the capsular constraint supports the humeral head, especially in abduction and overhead throwing. It is akin to what you give importance in knee to ACL. So why not we respect that? 18-year-old swimmer is a college student, professional keen swimmer, fell down from bike and then sustained the first-time traumatic dislocation. He's coming to our clinic. So what are we going to offer to him? The traditional approach had been to reduce the dislocation. You give him a sling support or an immobilizer for a short period, 3 to 4 weeks, and then start mobilization. And we consider surgery only if it is recurrent. But why do we need to still follow this traditional approach? The reason being surgery was not at all considered, maybe because in 15 years ago, we didn't have advanced technique in repairing a torn labrum or a dislocated shoulder. The commonest operation we know in the past is some sort of soft tissue putty plat operation in India 15 years ago. So it was nothing wrong with that tradition. Operate only when it is recurrently disabling. But do we need to still follow that? So that patient had an MRI and this shows the lesion. Because if you have a close eye and say you treat all dislocation conservative, you might miss the extent of injury. Here, this patient has had extensive soft tissue Bankart lesion starting from 2 o'clock to 7, 8 o'clock. As I said, that is a complete IGHL hammock support. But you also see it is an ALPSA lesion, that is the anterior labro-ligamentous avulsion. It is very easier to stitch this back to its place where it was torn. And it is also perfectly possible to have a perfect restoration of his inferior labrum and hammock. So why did we need to miss this opportunity and let this patient recur and have multiple soft tissue attenuation and also attritional bone loss and arthritis and discomfort? Do we need to do that? So 2 options we talked about. I touched on both of these. First is non-operative. Second is arthroscopic surgery. So when you think about non-operative, these are the various shoulder brace had been used in dislocation, grouped into a binder or strapping type, or a polysling, or an abduction brace, or a neutral rotation, external rotation brace. The importance came with Itoy paper in 1999, where he did a cadaveric study, simulated Bankart lesion, linear transducers attached to the labrum, and found the best coapted position was in adduction external rotation or abduction neutral rotation. He also subsequently did a MRI study to show that the best position is with external rotation. He followed this with the randomized study and showed a significant difference with the recurrence rate with patients treated with external rotation brace compared to sling, 30 versus 0. Soon, the market was full of external rotation, neutral rotation braces. In fact, we also did a study at Epsom General Hospital in England, but the study was discontinued because the patients were not compliant with the continuous wearing of external rotation brace. Note this one, there is a later he had a study in 2007, reported a larger trial, 198 patients, still showed a significant difference between the two groups. But this is not reproduced by studies elsewhere. This is a study from Norway, 2011. There was no significant difference between the internal rotation and external rotation group with regard to recurrence rate. Same way, there was another study, randomized study from Canada as well as Israel. There was no difference. So where do we stand as regard to external rotation brace in my practice? If I decide to do a conservative treatment, if the patient is younger than 30 years, I do not bother. I just mobilize as comfort allows. But older than 30 years, give the best of the benefit of doubt, give them a brace, because their incidence is also less, of recurrence is less with the conservative treatment. But the deciding criteria for me is age at the time of first dislocation, demand on the shoulder, and bony Bankart. We'll touch base each one of the points. So the second option we are talking right now is arthroscopic surgery. We are not talking much about role of open primary surgery in the first time traumatic dislocation. So what is the risk of leaving the shoulder to recur? There's the possibility of progression of the tear, labrum, ligamentous attenuation, capsular stretching. Repeated dislocation can lead to poor available tissue for later repair, the discomfort due to patient to repeated dislocation, and lastly, increased bone loss that might demand more invasive operation or increase the risk of arthritis. So what are, I'm a proponent of early fixation. So what are my arguments or supportive points to suggest to think about primary surgery for this group? Number one, reduce the recurrence rate. And second, improve function. We'll see one by one. There are only two factors that decide recurrence. Number one is age. Under 25 is 80 to 90% recurrence rate with non-operative treatment. And second is the activity, maybe the sports or particular demand on the shoulder in that patient. This has been proved beyond doubt. The RCTs on first-time dislocation, these were reported before 2004. They showed a significant difference in recurrence rate between non-operative and surgical treatment. But remember, these are all comparing to open surgery. So multi-center randomized control trial, conservative versus surgery by Jacobson in 2004 with 76 patients showed a dramatic difference of 9% recurrence with operated compared to 62% with non-operative at 10-year follow-up. And this is a level 1 evidence. So early stabilization improves function as evidenced by Dr. Robinson's study, but this is comparing arthroscopic stabilization versus arthroscopic lavage done for a primary dislocation. Later, this 2019, there is a prospective non-randomized trial, because the important thing is it is very difficult to do a randomized trial for a first-time dislocator, because we explain the fact to the patient. The patient should also get involved in the decision-making, and they cannot be blinded or randomized. It should be like a comparative trial. Most of the studies are. So in this study, if you look at it, the recurrence rate with arthroscopic treatment is 13% compared to conservative, which is 71%. But also note the return to sports to pre-injury level is 70% with arthroscopic compared to 41% with non-operative. The patient reported outcome as well as osteoarthritis were found to be significantly less with arthroscopic treatment with a final follow-up of 6.5 years. This study more or less give you a clear picture of the current arthroscopic repair practice rather than sticking to older papers. Now, as we are speaking, I came across this systematic meta-analysis. You can quote for your argument for this purpose. This paper has been just released in September 2020 in Orthoscopic Journal. It's a systematic review and meta-analysis of 10 prospective studies, 569 patients, showing 7-fold decrease in recurrence rate if you decide to treat the patient with arthroscopic surgery with a higher return to sports. The tabular column shows you the pooled recurrence rate is 9.7 in arthroscopy compared to 67 with conservative treatment. These are the patients under 25 years. Surgical intervention, that means recurrence after you have operated is 6% in arthroscopy, whereas 47% in conservative. And return to sports was 92 versus 80. So this is the data for showing there is drastic decrease in recurrence rate as well as improved return to play after arthroscopic surgery for first-time dislocator. So in my practice, I would say a 90% failure is converted into 90% success. So there is also other elements of fixation early. That is, number one is improving proprioception. As you know, there is neuroanatomical distribution of proprioceptive receptors in the capsule and in the capsular tissue, especially the anterior-inferior capsule. If you restore it, you get that function back. Reduce the risk of arthritis. The risk of arthritis is directly related to the number of dislocation as well as the extent of original damage. So this is the beautiful paper from Griff showing that more dislocation is equal to more glenoid loss. It is common sense. And various papers show very clearly age at primary dislocation, number of dislocation, a bony glenoid rim lesion, and a high energy sports are in fact the risk factors and not surgery. The surgery, in fact, is proven to reduce the risk of arthritis. You are reducing the incidence of repeated dislocation that is going to cause damage to the glenoid and the femoral cartilage. So as up to 33% reduction in arthritis has been observed. Finally, when we talk about surgery or non-operative, we have to decide what surgery we offer. When we offer open surgery, we have results, problem with the results and also risk. But here, when we offer arthroscopic stabilization, what we are offering is Bankart repair, soft tissue, a anterior-inferior and posterior-inferior labral repair, average 3 anchors, a capsular labral plication, recreating a bumper effect, and early rehab. So as per this technique, we used various metallic anchors, bioabsorbable anchors, peak anchors, but these were the things of the past. Of latest use is the all suture anchor. So where you don't even leave any metallic or polymer residue in the glenoid socket. So we use stitch on stitch and repair it with minimally invasive disruption to the glenoid. The risk of arthroscopic surgery is very minimal. The benefits are many. It's a less complex procedure, anatomical repair, the range of movement is preserved, 90% success rate, proprioception is preserved because you're restoring anatomy back, reduce the risk of arthritis and bone loss. So these are the arguments. So let us see some cases. So this, as well as we'll just talk about the type of soft tissue lesion. A 23-year-old man with acute dislocation after playing badminton. That is the injury. As you see, there is an ALPSA lesion. That's osteoperiosteal ligamentous avulsion, as well as a heel sac lesion, but it is not depressed yet because it is only a first-time dislocation. That's the lesion. As you see the arthroscopic picture. Can we just see that? Well, it's not playing. Okay. So that is the postero-inferior labrum. I repair through the posterior route. As I said, is antero-inferior to posterior. It's 2 o'clock to 7 o'clock is the usual. So I repair the postero-inferior labrum first from the posterior route. Dr. Keynes is going to talk about in detail. So then I proceed to anterior labrum, repair with at least 2 to 3 anchors, especially the anterior-inferior. I do not particularly go for repairing the labrum at 12 to 2 o'clock, that is a superior, antero-superior portion. Once you do that, it is a juicy labrum, a fresh torn labrum. You don't need to do any preparation to prepare the glenoid bed. You just need to put the anchor and stitch it back. So that is came at 3 months follow-up, achieving full range of flexion, abduction, and also external rotation. And that is 3 months follow-up. This sort of proprioceptive recovery is possible with arthroscopic repair. Let us see another example, 22-year-old first-time traumatic dislocation following road traffic accident. As you see, there's a lot of signal in the superior labrum as well as fluid around the long head of biceps. And you see the anterior labrum Bankart lesion. But most commonly, they can be associated like this. If you see this, there is the anterior labral tear, but in association with the bucket handle type of superior labral tear, as you see down, you would see the subscap there, and that is the anterior labrum up to 6, 7 o'clock position. So once you do that, if you let this patient non-operative, it will go on repeated dislocating, and everything would be torn apart, and there won't be any soft substance to repair for a future if it dislocate happen. So here we did type 3 bucket handle type of tear with the superior labrum first. There are people who do the anterior labrum and come back to superior, but I decided to do the superior labrum first to restore the labral drain with the posterior simple suture anchor at the 11 o'clock position, followed by anterior labral repair with the 3 anchors. So that is the plan. That is a completed repair. We put additional PDS suture to repair the bucket handle tightness. So that is the finished repair. Okay, so that is him at 3 months post-operative. And that is the MRI at 1 year follow-up showing the location of the 4 suture anchors on the anterior labral repair. It's back to restoring normal anatomy for him. So another case, just to mention, if you have a primary anterior dislocation with the bony rim fracture, pay attention and be careful. Do not leave them for conservative treatment, because with the attritional repeated dislocation, they go for accelerated bone loss. Okay, so this is the subset of a primary anterior dislocator who will benefit from early arthroscopic surgery. And Dr. Chirag is going to talk about it in detail, but I'm just mentioning it for completion's sake here. So that is the arthroscopic picture view from the anterosuperior portal. You see the IGHL ligament avulsion with the piece of glenoid fragment rather than soft tissue Bankart. So here we decided to repair arthroscopically, 1 anchor below, 1 anchor above, with the compression of the bony fragment. If there is a big fragment, you can also do a double row repair. So that is the completion of repair. That is a slap lesion. I did repair the slap as well. So that is his 3 months post arthroscopic repair. Very well congruous joint with the well-healed glenoid labrum. So we showed the first patient. What did we do for him? So that is his MRI scan, and he had orthoscopic stabilization, and that is 1 month follow-up, 1 month of 5 weeks. Because we have now techniques that can securely repair the soft tissue Bankart to where it belongs. There is no need to do any additional remplissage or additional procedure for heel sac lesion, because there is only an impact. And we can be confident of bringing a good result for these patients. So in conclusion, traumatic first-time anterior dislocation with the age less than 25 years, with the active life, of course, they will be, with a high demand on shoulder like athletic population, and extensive labral lesion or a marginal glenoid fracture, at least make them aware of early surgery as the option. Thank you.